Assalamu alaikum. A very good morning to you all. I welcome you all to ICON 2022. I am Dr. Mehmood, consultant family medicine, and I'm happy to announce this session on lifestyle medicine, arranged by the Department of Family Medicine at the Indus Hospital and Health Networks. Lifestyle medicine. In the developed world, lifestyle is one of the major determining factors concerning the health condition of a population. A high percentage of medical consultation in primary and specialist healthcare are due to lifestyle related issues, which are therefore preventable. Likewise, the great majority of practice guidelines recommend lifestyle changes as the first line of treatment. Consequently, lifestyle is not only a public health issue, but also a very clinical relevant issue in current therapeutic management of illness, especially chronic pathologies. The advent of lifestyle medicine seeks to resolve current shortcomings and provide continuity between preventive medicine and patient centered clinical practice. Lifestyle medicine focuses on all six areas to improve health, which include physical activity, managing stress, forming and maintaining social relationships, improving sleep, avoiding substance use, and healthy eating, which we'll be discussing today in our session. Let's start with the first presentation of the session, which is on the importance of healthy lifestyle, including healthy diet and physical activity, by Dr. Sadaf Mustafa. Dr. Sadaf Mustafa is an assistant professor and medical director at medical management clinics and faculty internal medicine at Medstar Health and Georgetown University School of Medicine. She's a board certified internal medicine physician from USA with fellowship in obesity medicine. She also holds a fellowship designation from the American College of Physicians, which is awarded to few physicians who excel in their field. We are happy to take question answers immediately after this session, specifically as Dr. Sadaf is joining us from US. Over to you, Dr. Sadaf.
Good morning. This is Dr. Mustafa. Thank you for having me today to talk about this very important topic. I do not have any disclosures. My objectives will focus upon obesity statistics, definition, screening method, approach to a patient with obesity, and then treatment pillars, which includes behavioral therapy, nutritional therapy, physical activity management, and medication management. Now, obesity is an existing pandemic. It was here way before COVID-19 pandemic. If you may see, this is a world map and almost all of it is red, which means that the prevalence of obesity is somewhere between 15% to 70%. Now, in this point in time, Pakistan's prevalence is predicted to be close to 8.6%. However, I would want you to take it with a grain of salt because here the BMI cutoff used is 30 and above, which is different than the Asian Pacific classification. Now, this is just an overview of how rapidly the world has acquired obesity as a chronic disease. In 1975, sorry, since 1975, the rate of obesity has tripled. In 2018, WHO published a very nice report which included countries profile that are part of WHO, and it was all about non-communicable diseases. You may see that in 2016, 39% of adults age 18 and above were overweight, which basically means 1.9 billion adults, and 13% had obesity, which translates to 650 million individuals. At the same time, they looked into the age group between 5 and 19, and it was identified that 340 million children and adolescents suffers from obesity. Later on in 2020, there was another set of data published that looked into more younger kids, and there were 39 million children under the age of 5 who had overweight or obesity. Now, what exactly obesity is? It's a chronic disease, progressive, multifactorial, relapsing, neurobehavioral disorders. It has metabolic, biochemical, and psychosocial consequences. So, obesity, unfortunately, is the root cause of a lot of other chronic diseases, including diabetes, hypertension, obstructive sleep apnea, insulin resistance, cancer, atherosclerosis, among a lot of others. Now, this is again a report by WHO in the same profile report, which was published in 2018. It looked into the deaths, the global deaths that are happening due to non-communicable diseases. As you may see on your right, is from like 71% of the 57 million global deaths were contributed to the non-communicable diseases. And similarly, in Pakistan, it's pretty much the same. It was about 58% of all deaths were contributed due to non-communicable diseases. Now, why this is important? It's important because non-communicable diseases, as I just mentioned, the root cause is one of the root cause is obesity, and it's a preventable disease. If we are able to make a difference there, we should be able to bring these numbers down. Now, what happened was that they also documented some trends. So they compared what's going on between obesity and other chronic diseases. And I just picked up one example. If you may see, it's predicted that in the next 5 years, the rate of obesity in Pakistan will actually go up more in females than males. And similarly, the people suffering from hypertension will also go up more in females than in males. However, the global targets are set at a much lower rate, so we need to start working and making differences. Now, why does this happen? It happens due to a lot of different causes, but some of the most important one are increase in caloric intake, pregnancy, some genetic contribution, family history, a sedentary lifestyle, some environmental factors like lack access to healthcare, not having this identification that unhealthy weight is actually a problem, and then some medications are very weight positive that could also contribute to weight gain. So knowing all this, what should we do? Why are we here today? We have to start screening these patients for obesity. And this is a US task force recommendation that came in a few years ago indicating that individuals 6 years and older should be screened for obesity. It's a grade B recommendation, which means it's highly encouraged. Now, how can you screen, your patients with obesity? There are two different ways of doing it. One is looking into the body mass index, and the other is the body fat percentage. Now, when you look into the body mass index, there are once again two different classifications. One of which is very much geared towards the Asian population, and the other one is the one which is usually globally used. I'm going to start with the one which is globally used, where the normal weight is defined between 18.5 to 24.9. However, obesity is classified as 30 to 34.9, and then it goes up with class as we proceed with the class of obesity. However, the Asian Pacific Task Force has recommended to change the cutoff point of Asians based on their body frame. So it's now recommended that the normal should be between 18.5 to 22.9, and similarly, obesity is defined as 25 and above. This has to be compared with waist circumference, and I'm going to talk about waist circumference a little later. But all I wanted you to understand is that the classification which is recommended to be used in Asians is different than the other classification I spoke about. Now, what about waist circumference? Now, I would like you to understand that the BMI is a very good tool for screening. However, if you have a very muscular individual, or if you have an individual who has a lot of adiposity centrally, or the BMI is more than 35, unfortunately, it doesn't give you much of an information. So in that situation, you can use waist circumference, or you can use a body mass, fat composition analysis, like a body composition analyzer. Now, the waist circumference is also important in those individuals where you see that your patient is actually overweight, but when you do the waist circumference, it's coming up higher. Like for example, in Asian males, if it's more than 90, it's classified as obesity, and in Asian females, if it's greater than 80 centimeters, it's classified as obesity. So if you have a patient, the BMI is overweight, but the waist circumference is pointing towards obesity, these are actually the individuals who are at a very high risk of having cardiovascular mortality and morbidity. Now, how to do the waist circumference? There are two different protocols. Whichever you pick, please make sure you are able to reproduce it, because if you're moving between one point to another, you will have a difference. So the WHO protocol measures the waist circumference as a point which is taken midway between the highest point of the iliac crest and the bottom of the rib cage. However, the NIH recommends to take the waist circumference at the highest point of the iliac crest. Now, coming to the percentage body fat, what the percentage body fat is, it's actually compartmental analysis telling you that if your patient's body fat percentage in a male is more than 25% and in a female more than 32%, it indicates that your patient suffers from obesity. Now, how do you do it? There are body composition analyzers available, and they can go all the way from two compartments to four compartments. Two compartments mean just the fat mass and the fat-free mass, whereas all four compartments will go from fat-free, body water, minerals, and protein. So it will give you a detailed analysis. This is an example of body composition analyzer. However, there are scales also available where you have two touch points and you can get the same information. The most important thing is that if you are buying a commercial scale with two touch points, the numbers may not be as accurate as it is with a body composition analyzer with multiple touch points, or at least four of them. But if you do use one of them, make sure you're looking into the trend when you are bringing your patients on the serial visits. Now, Edmonton obesity classification basically looks into your patients who are suffering from a comorbidity associated with obesity. If you have a patient, for example, say has hypertension, but hypertension is very well controlled, I would say the patient is in stage two of the EOS. But if your patient has, say, for example, because of hypertension, develop other problems, uncontrolled hypertension, having stroke, having cardiovascular disease, having MI, so now your patient is progressing from stage three to stage four. Usually, stage four are individuals who are pretty much at the end stage of their disease and are unfortunately dependent upon a lot of medications and or in hospice. Now, let's talk about approach to your patients with obesity. When you see these patients in your office or in your clinic, make sure you get a good history, perform physical examination, look into the preventive health care, do pertinent investigation, and come up with a good treatment plan and very close follow-up. When taking history, the most important thing is to understand about the dietary pattern of your patient. What exactly are they eating these days? You know, what are they consuming? What they have done in the past? What has worked for them or what has not worked for them? Did they ever lose weight? And if yes, what did they do? So these questions are kind of important. Now, talking about physical activity, you have to make sure you know about your patient's baseline. If you have a patient with severe osteoarthritis and the patient cannot even move around, so really you cannot give them a plan that you will be giving to a 30-year-old active boy or a male, you know. So you have to know about how much they have done, how much they can do, and what they are doing. With behavioral history, it's important to screen them for depression, for eating disorders, for anxiety. Socioeconomic history is important because you need to know what your patient is doing actually. Are they able to afford the treatment that you're going to suggest? Surgical history important because you will have patients with bariatric surgery. So their management may be a little different than those people who have not had been through a surgery. Sleep history, once again, we have so many studies indicating that if you are not sleeping well, at least between 7 hours, 5 to 7 hours, you will actually be having more problems. Individuals who sleep less than 5 hours, or sleep more, less than 10 hours, suffer from obesity. You have to look into the prescription medications, talk about over the counter medications, social support, and family history. Now, some of the screening questionnaires that I use in my practice are GAT2 or GAT7 for anxiety, depression, PHQ-2 and 9, binge eating disorder questionnaire for obstructive sleep apnea, stop band, mood disorder questionnaires, the exercise capacity of my patients, asking about how much they can do. Like you can ask them, can you walk a block without becoming short of breath, just to have an idea that it is, you know, a metaphor, or you can ask them, okay, can you run or do you do treadmill? So the more and more they do, you will have an idea of their next. Similarly, some individuals, we may need 6-minute walk to understand their pulmonary and cardiovascular capacity. Now, when you're doing a physical examination, please concentrate on some of the obesity related clinical findings. You are looking not only for insulin resistance, you're looking for primary obesity, you're also looking for secondary causes of obesity, and you are looking into other associated complications. So these are some examples like acanthosis nigricans on the very top. Then you're looking into lymphedema or lipedema. They both are two different conditions. Make sure you're able to recognize them because the lipedema is an inherited disorder. Your patient will present in the form of bilateral swelling in the lower extremity, which is non-fitting. They will have a positive cuffing sign, like they will have very narrow ankles. They will have small waist, and some of them may even have large upper extremities. But this is different than lymphedema because you will have more like pitting edema. It may have unilateral or bilateral consequences. And the lipedema, you will feel like beanie babies when you touch them. However, it's going to be a soft swelling. And the foot may actually be involved also in lymphedema. You may want to look for purple striae to look for Cushing's disease, palpate the thyroid, and get your Mellampati score. The Mellampati score basically looks into the distance between the back of the tongue and the soft palate. So as the distance goes down, the score goes up. This was actually used by anesthesiologists initially, but we use it to look for possibility of obstructive sleep apnea. Now, preventive healthcare is important because if your patient is losing an unhealthy amount of weight, you would be kind of worried in one point in time, thinking that, oh, is there anything that I missed? Is there a cancer? The patient is losing that amount of weight, and you will tend to ignore that this is actually the hard work of the patient. So when you see a patient with weight loss, make sure you ask about intentional versus an unintentional weight loss. And in order for you to satisfy your own self and satisfy the protocol, it's a good idea to screen them first for preventive healthcare, keep them up to date so that you're not confused about your efforts. Now, some investigations are general investigations, like, for example, screening for diabetes, looking into cholesterol, getting a liver kidney function test, looking into the electrolytes and thyroid function test. I do get vitamin D levels. There is no direct association between obesity and vitamin D, but we want to make sure that our patients are not nutritionally deficient and are not having falls or feeling depressed or having musculoskeletal aches and pains because of vitamin D deficiency. Some investigations are very specialized, like as I mentioned, if you want to do body composition analysis, you want to screen your patient for PCOS based on the symptoms. If you think it's Cushing's, you want to do overnight dexamethasone suppressant test. If you want to do an EKG, echo, or cardiac express test, depending upon what your history questions were, what was your evaluation. You may want to get a pulmonary function test, and you may want to get a sleep study based on your interview with your patient. Now, coming to the treatment pillars. 4 pillars, very important. I will be focusing on almost all of them, but when it comes to medication, we will be doing one of the essential components today. Now, behavioral therapy. When you are having a patient in your office and you're having a discussion, make sure that you identify where exactly your patient is in the stage of change. What that means is that you will see a lot of people coming to you and saying, oh, I want to lose weight, I know my weight is unhealthy, and can you please help me? But when you start talking to them a little bit more, there will be a disconnect between their thought process and their actually making effort for change. So this is actually a trans-theoretical model, which is used in a lot of different conditions like smoking cessation or alcoholism. You can use the same model to kind of having an understanding of where your patient is. If your patient is not yet ready, it's going to be a pre-contemplation stage. If your patient is already ready, it's going to be in preparation phase. If your patient is already doing what they're supposed to do, they will be in the action phase and they will keep on going to the maintenance unless they relapse. 5 A's of obesity management are very important. It actually starts off by getting permission from your patients, making sure they are comfortable when you are talking to them about their weight. And then you have to assess the comorbidities, advise a good treatment plan, They have to agree with your plan. The plan should actually come from them more so that it should come from you. And you should assess and get them closer follow-up appointments. Set up smart goals. You know, don't set up a goal like with your patient that you're going to lose 50 pounds in 6 months. I promise you that's going to happen. Please don't do that. It's important that your goals are very specific. We know that clinically significant weight loss is defined as 5 to 10% of the current body weight. So that's what you should set up with your patient. This should be measurable. You tell them, okay, now you're going to weigh yourself once a week, and I'm giving you a goal of X amount of weight. Please make sure that you write it in your journal and bring it to me, and you're weighing yourself once a week. It should be achievable goal, not a dramatic drop that your patient is not able to do and then get depressed or disappointed. Make sure it's relevant to your patient, not actually relevant to you. So your patient should have to have a drive as to why they want to lose weight. Do they want to get rid of, say, for example, diabetes, or they want to lose weight because their daughter's wedding is coming? So you need to first of all see where exactly your patient is, and has to be time bound. You have to tell them that you're going to hold them accountable if they are unable to do this, and then you need to talk about the reason as to why this is not happening. So let's talk about an example. You have a 55-year-old male, who has hypertension, hyperlipidemia, pre-diabetes with an HbA1c of 6.3, who's screened positive for obstructive sleep apnea, and his weight is 133.2 kilograms. Now, how we can set up a smart goal for this patient? As I already discussed, 5 to 10% of weight loss, gonna be 7 to 14 kilograms in 3 to 6 months, and then we bring it down to about 1.25 pounds per week. I mean, it seems a very odd number, so you can just tell them, you can do between 1 to 2 pounds. Let's see if you're at least able to achieve 1 pound per week. Now, make sure your patient is able to track their weight loss journey in some way. We encourage patients to maintain daily logs, or they can act, and they should also be using a step tracker like a pedometer, or they can actually use a phone to track their steps at the same time. You want to encourage them to track their miles if they are using treadmill, resistance training. And then when they are following up with you, you can weigh them in your office or measure their body fat. Now, coming to nutritional therapy. General principles for nutritional therapy include coming up with a diet plan which is safe for your patient, is effective, easy to follow, has negative caloric balance, and then is sustainable. That's important. It has to be sustainable. Discourage refined food consumption, discourage processed food consumption, and your plan should be very individualized to the patient who is in front of you. Now, this is just a slide to give you an information, but I would just give you the highlights. The normal daily intake for carbohydrates is between 120 to 150. This is just for you to have an idea. 150, 130 average, 130 grams per day. The fat is about 30 grams per day. Similarly, for proteins, it goes from 0.8 to 2 grams per day. A lot of the times, our patients are not actually having enough proteins. That is also one of the reasons why they're craving. Now, further into the nutritional therapy, as I mentioned, you have to have a negative caloric balance. There are two different type of diets. You have to look into either a low calorie diet or a very low calorie diet. When we're talking about a low calorie diet, the diet is between 1200 to 1800 calories per day. When we talk about very low calorie diet, it can go all the way to 800 calories per day. First, when you set up that, then you have to decide whether you want your patient to be using a low carbohydrate diet or a carbohydrate restricted diet, or you want to do fat restricted diet. Once again, this will be based on the metabolic profile of your patient. And then from there, you can decide which type of carbohydrate restricted diet you want to do. The same principle applies for the very low calorie diet. Now, going back to your patient, I already, kind of shared that the weight was 133.2 kilograms. So we decided that this patient should actually have low carbohydrate diet, but you start off by a caloric restriction of 1200 to 1800. Now this is low calorie. This is not very low calorie, okay? And then you did low carbohydrate, which was between 50 to 150. Say, for example, I want to do very low, I would have to drop the carbohydrates a little further. At the same time, the proteins was 0.8 to 2 grams per kilogram per day. So for him, we did 1 gram, and it was between 100 to 120 grams per day. Now, say you have the same patient, but now you want to do fat restricted diet. In that, again, you have to select low calorie diet. We did between 1200 to 1800. Imagine you selected 1500 with your patients and he agreed. Then you will do a low fat diet. And remember, this is a very low fat diet, which means that the percentage of the calories coming from fat is 10% or less. If this has to be just a low fat diet and not a very low fat, it will be 30% and below. So in this individual, where we did 1500 calories per day and we wanted to do very low fat diet, we selected 10% of the calories assigned. So it will be 150 grams per day. Now, this includes both saturated and unsaturated fat. Okay, in very extreme conditions, I have actually dropped the total fat intake for the unsaturated fat to 3 to 5%. So that is one diet that American Heart Association also recommends for people who need, a lot of help. Now, coming into proteins, we did pretty much the same thing, 1 gram per kilogram per day. Now, say if the same patient you want to do very low calorie diet. Okay, now what about that? Now here you drop the caloric intake between 800 to 1000 calories per day. And then at the same time, you drop the total carbohydrate intake to 20 to 50 grams per day. And you did protein the same 1 to 2 grams per kilograms per day. Now, this is very important for you to understand that when you're going that low on the calories, a lot of the time the nutrition and the proteins you may not be able to obtain in regular foods that you're consuming, because most of the foods that are rich in proteins, like for example, say meat, tofu, are very high caloric. They're dense in calories. Now, so what can we do in that situation? You can use some meal replacements, and actually Pakistan has a lot of websites. I just put it in my reference, and you can reference them, where you can get these meal replacements even online. Some of the big names that we use commercially include Ensure Max, Boost Max, Premier, Protein Shake, Slim Fast, among others. Now, why meal replacements? Because meal replacements are designed to be less in calories, high in proteins, and less in total carbohydrates. As you may see, this is an example from Ensure Max. The total calories are 150 per bottle. The patient will get 30 grams of protein per serving, and the total amount of carbohydrates is 6 grams. Now, make sure that you teach your patients to look into the total carbohydrate, not into the total sugar, because carbohydrates comes from a lot of different sources and a lot of different types. So they should be looking into the total carbohydrates so that they are not getting confused with the sugar and the carbohydrates. Now, physical activity. I want you to understand the concept of daily total energy expenditure. It actually comes from 3 different ways. One is your resting energy expenditure. Second is your energy expenditure from physical activity. And the third is the thermic effect of food. Now, what you can actually change is the energy expenditure from physical activity. It comes from 2 different, I would say, arms or ways. One is performing exercise, and the other is NEAT, which is your non-exercise activity thermogenesis. What that means is that you are doing things for your leisure time, which are more physically active. You are walking more than driving, and you're occupationally, you're busy, you're walking and you're moving around, and for example, say a security guard and things like that, that you're very, very physically active. So that actually contributes towards changing your energy expenditure coming from physical activity. Now, whatever you select for your patient, make sure it's enjoyable for your patient. It will increase in their energy expenditure from physical activity. I also recommend increasing their NEAT. Focus both on aerobic training and strength training. Aerobic training you can do between, if they are doing rigorous physical activity, which is defined as, for example, say running on the treadmill at 4 or 4.5 speed. And then you can also recommend doing 2 sessions of strength training, 30 minutes each. That is per week. So all this is per week. American Heart Association also recommends that perhaps they can just start from 30 minutes of brisk walking every other day. Now your patient is here. Your patient used to go to gym 6 months ago, not going to gym no more. It's pretty sedentary. What do you want to do for your patient? Assess your patient's met, recommend at least walking 30 minutes every other day. Consider basketball coaching again because he used to enjoy that in the past. Now, medication management. In the best interest of time, I will only be talking about medication list review. However, there are alternative medications that patient takes for weight loss. Make sure you look into them and make sure they're not harming, because actually in literature, there are not much of the things that can be used as an alternative medications to help with lose weight. I will not be talking about anti-obesity medications, but that's another big arm that can be used to help your patients to lose weight. Now, when you're doing medication reviews, please make sure you eliminate weight positive medications. Among the antihypertensive, a big example is beta blocker. Among anti-diabetics, a big example is sulfonylurea and insulin. Hormone therapies, prednisone, and your Depo-Provera. Anti-seizure medications like valproic acid, carbamazepine, they both are weight positive. Antidepressants, your TCAs. Mood stabilizer, lithium. Migraine medications, once again, the beta blockers, antipsychotics, olanzapine, chemotherapeutic, tamoxifen, anti-inflammatory, your ibuprofen, diclofenac sodium, they can actually increase appetite. Now, your patient actually has hypertension and has hyperlipidemia, and they are taking atenolol and atorvastatin. As mentioned earlier, this can be changed to an ACE inhibitor or an ARB. For high cholesterol, consider moving to pravastatin. We have few studies indicating that it's a little bit less weight positive as atorvastatin. And also, when you're doing all this, look into your patient's cardiovascular risk factors, speak to their cardiologist, calculate their ASCVD risk in this patient. He qualifies for a medium potency statin, and he has an intermediate risk, so I was able to change to pravastatin. Similarly, for pre-diabetes, consider metformin. We have enough literature indicate that metformin can actually help with insulin resistance and may help ultimately with weight loss. Now, in summary, screen your patients for obesity, use 5 A's for motivational interviewing, explore and address the readiness, devise a personalized plan, and not, remember, one shoe is not going to fit all. So you need to know what exactly you're doing for that specific patient, and the patient needs to agree. You have to do proper motivation interviewing for them to agree to your plan. You have to consider multidisciplinary approach. You may need a behavioral therapist. You know, you may need an exercise physiologist. You may need a dietitian, and you yourself. Or if you have enough time, you may be all of them. Other than that, make sure they're food journaling. They can do it online or they can do it on paper. It doesn't matter. CDC has beautiful things out there. You can get download free food journals, food logs, or they can use free apps like Fitbit, MyFitnessPal, calorie counting. You know, there are so many out there. And when they're coming to you, make sure they bring their log with you. Do 24 to 48 hours recall so that you can address the gaps and help them a little bit more. So let's fight obesity together. Thank you so much for listening. These are my references, and I will take questions now. Thank you.
If you have any questions for Dr. Sadaf, please write them in your chat box. Okay, Dr. Ashrafun Nisa is asking, can you please explain the role of hypothalamus for decreasing craving for food? Can such medication be prescribed?
Hi. First of all, thank
Hi.
you for having me. I really enjoyed the session. So yes, what's happening is that there are different centers. Usually, most of them are, hypothalamic centers and are pituitary. And actually, there are genetic disorders, leptin deficiency, and MCR4 receptor mutation, which if it's present in your patient would benefit from a specific medicine which is known as sen melanocyte. So yes, there are treatment. They're infused in the form of like an infusion. They were just approved in 2020, and definitely there's a big role. However, having said that, in the satiety center and your center for hunger, all is actually very, very close to hypothalamus, is actually just around in that area. Some of the preventricular nuclei are involved in the whole process. And a lot of our medications like naltrexone and valbuterol combination that comes under the name of Contrave can actually be used. Topiramate also has a lot of inhibitory effects, and even your GLP-1 analogs can be used. They have some center receptors that they target. I hope this answered the question.
Okay, thank you.
Mhm.
Anybody else has any questions? Please write in your chat box. Okay. Okay. Dr. Anam Zaidi is asking patient with PCOS and hypertension and diabetes in age 30, which medication is best for weight reduction?
Actually, it's a question that is often asked. So I guess the most important thing would be to see if that what's the BMI of your patient. That's from where I would start. So if your patient is Asian and has a BMI more than 27, and I would look into the HbA1c. Even if there are no signs of insulin resistance on the HbA1c, I would actually do a morning fasting blood sugar and a morning insulin level. There is an index that you can calculate by the name of HOMA-IR. This tells you about the insulin resistance in the patients, actually for any given disease, but specifically in your patient, you can use the same thing. And you can prescribe them metformin. That would be helpful. We have some studies that have shown that you can have a weight loss of about 8 pounds, between 4 to 8 pounds with metformin. However, any medications that you prescribe, it's very important that you add some sort of lifestyle intervention, because that is like the cornerstone of everything. The medications are just a help to those patients. I
Okay.
hope I answered the question.
Yeah, yeah. Dr. Aisha is asking, can you please comment on the role of keto diet to decrease weight?
Yeah, yeah. So I can tell you I'm not a fan of keto diet, but it's like out there everywhere. Everybody is using it. So I would say that if you have to use ketogenic diet, make sure that you are doing it for a short period of time. It works. It definitely works because you have to drop the carbohydrates significantly. Patients usually take between 20 to 50 grams of carbs. Most of them end up at around 20. It is when you have to put the body into ketosis. I know in Pakistan you can actually find those strips and check in the urine if you are in ketosis. But the only place where I would say I would not like to use it if your patient has significant hyperlipidemia, because it can inadvertently increase the LDL in some people. And if you have patients with familial hyperlipidemia, I would kind of shy away from using, especially at the primary care level, because this needs a lot of patience, a lot of close monitoring. It has I would say it works. It's a short diet, a robust diet. It's not a lifestyle change. It works, but it has some side effects. So side effects include hair loss, which is very common. It includes excessive wrinkling of the skin. It also includes, in the beginning, muscle aches, pains, some nutritional, not nutritional, but like micronutrient deficiencies. So if somebody is doing ketogenic diet, I would highly recommend to get some baseline blood work, which would include thyroid function test, which should include like vitamin D level, vitamin B12 level, also looking into the kidney and liver function test in the beginning, and the lipid profile. HbA1c definitely would be helpful, but that's going to come down. It's actually one of the diet that works very well in diabetics if they are able to do it, because this diet really needs dedication. So if they are able to do it and the cholesterol panel is not bad, you can use it all the way up to 6 months. But after that, you have to induce, we call it as reintroduction of carbohydrates. So you have to reintroduce it. You can do like close to 10 grams per day, and you can slowly and gradually bring your patient to above 50 grams and maybe leave it between 50 to 100 grams. That is where they're not going to have a lot of problems, and hopefully they'll be able to maintain the weight loss.
Okay. Can diabetes go with keto diet? There's another question.
Yes, yes, yes. So it's a very good question. So we have done it in type 2 diabetics because you see type 1 diabetes people are prone to get acidosis. So, and again, at a primary care level, I would discourage you to try it on type 1 patients because it needs a specialist to do it. But in type 2, you can definitely try it. And as I said, you have to monitor your patients very closely. You have to see them every week because they lose weight very fast. And if they are on insulin, they are at risk of having hypoglycemia. So it's like a whole different topic, like how you can manage people with diabetes and ketogenic diet because you have to be very careful that they will become hypoglycemic if they are on a very high dose of insulin. So honestly, what I do in my practice is that I put them on very low carbohydrate diet and low caloric intake, like 1500, and then I wean them off of insulin slowly, and it comes down very nicely. So I don't have to put them into ketosis in order to get rid of insulin. I can just do that. And yes, you can do it in type 2 diabetes, but not in type 1.
Okay. Will you recommend intermittent fasting? Which window is effective? 12 hours, 14 hours, or 16 hours? Dr. Sobia wants to know.
It's a very interesting question. So I must say there was a publication not too long ago that showed that intermittent fasting works very good in patients with diabetes. It actually improves the HbA1c significantly. So I think it's good news for everybody who fasts every Monday and every Thursday because that's gonna. I think that's like I'm like, oh god, we already know about it. And anyway, so that's another thing that just turns me on a little bit. But I guess it's a good question. It all depends upon how much you are able to cut down on your total caloric intake. So, if you are, say, for example, doing the window of 14 hours, but then whatever time you have, you are overdoing on your meal. So, the principle is that you have to cut it down between 45 to 75% of the caloric intake that you do. So if you're doing like 2000 calories, you should be able to bring it down again at least by 500 calories. And then you're allowed to eat those 1500 calories during X amount of time. It doesn't matter really which one you are doing as far as you're able to cut it down by 70, between 45 to 75% of your diet. So the more you go down on the calories, the better the outcome is. But I mean, I can tell you most of us gain weight in Ramadan. And the reason being is because when we are allowed to eat, we overdo it. It could be an excellent example of intermittent fasting, but if we actually follow the principle of intermittent fasting, and that is cutting down on the calories, I know that the trials has been all the way up to 75%, which is very low. Like you'll be having like 800 calories a day the time that you're actually eating. So my recommendation would be to cut down on the amount of calories. Start by cutting down 500 calories out of whatever you're taking. So create a negative calorie balance and start off by 12 hours because you have to allow your body to get used to the new structure. Once you are used to the new structure, you can always move to the 16 hours.
Thank you, Dr. Sadaf, for the enlightening talk. It was really exciting. Okay, now we'll be moving to our second talk of this session, which is on substance use disorder. Dr. Mohammad Tarique will be giving an insight on this. He's an assistant professor of psychiatry at the Dow University of Health Sciences and Benazir Shaheed Anti-Narcotic Force Model Addiction Treatment and Rehabilitation Center, Karachi. He's a graduate of Dow Medical College and has completed his residency in psychiatry. He's a national and international trainer for Universal Treatment Curriculum for Addiction Professionals by Colombo Plan in Pakistan. He has represented Pakistan in many national and international conferences on addiction treatment and rehabilitation services for policy, training, and advocacy. He has 6 publications to his credit. Over to you, Dr. Tariq.
Honorable Chair, respected co-speakers, and dear participants, Assalamu alaikum. I am Dr. Muhammad Tarique Arain, Assistant Professor of Psychiatry, Dow University of Health Sciences. Today, I am going to present the substance use disorder topic. According to Shamsa, the current use of alcohol drug causes clinical significant impairment, including health problem, disability, and failure to meet the major responsibility at work, school, and home. Is called substance use disorder. According to the Diagnostic Statistics Manual 5, a problematic pattern of use using alcohol and any other substance that results in impairment in daily life and noticeable distress in life, defined as substance use disorder. According to DSM-5, we classify according to the symptoms present in the in individual within the 1 year of time. More than two and symptom are present meet the diagnostic criteria of the substance use disorder, which mainly is craving, tolerance, withdrawal, self-neglect, deterioration of functioning, and social isolation. Keeping in the topic related, I would like to highlight the pandemic decades of the drug substance use in world. In 1970s, the heroin is the most commonest drug used all over the world. In 1980s to 90s, the cocaine trend is emerging. Then later on in 2000 and later on, the ATS type stimulants are more prevalent in overall world. And in 2010 and onward, prescribed drugs are opioids and opioid derivatives are most common. In 2020 and later on, cannabis and benzos are most commonest drugs in world. These are the graphs of UNODC of year-wise prevalence of substance use in overall world. Overall, 269 million drug users in world, which was the 5.6% population of all over the world. Keeping in this scenario, we will like to the highest risk factor of the death of the world is substance use. If you include in some smoking, alcohol, and drugs, that is the largest one risk factor of the death in overall world. These are the current pandemic situation, trend change in substance use. Before this pandemic, the meth users, ATS user is most common, but after that pandemic, the cannabis use and benzos use are increased. Coming to the Pakistan situation, overall, Pakistan has 6.8 million drug users according to 2012 report of UNODC, which was the 5.6% of the population is using drug. Among them, 4.2% of the population is the drug dependent. Coming to the gender-wise prevalence, 9% prevalent in women and 2.9% in women in Pakistan. These are the province-wise distribution of the substance use. Highest prevalence in KPK, then Sindh. In Pakistan, overall, the drug prevalence, most commonest is 4.3 is cannabis use. According to we classified according to psychoactive substance or drug class. Psychoactive substances are those substances which are alter the effects, mood, thought, perception, and cognition of any individual called psychoactive substance. Broadly, we divide into stimulant group, opioids and narcotics group, and dependent group, and halogenic. These are division on the nature of the drug according to their property and CNS effects. Coming to the major classification of the drugs, we will like to discuss the first cannabis use and their effects on body. And if in any individual using cannabis started with cannabis, his thoughts, coordination, concentration, mood changes, swings, hallucination, and schizophrenia may be developed. If they comes in the intoxicated state, their rapid heartbeat, loss of coordinations, euphoria, sleepiness, respiratory depression. When they comes in the withdrawal effects, after the 12 hour, 24 hours, they started a withdrawal symptom after stopping the cannabis. They started irritability, agitation, restlessness, mood changes. Probably this comes in, you can detect it. Withdrawal comes in Opioid binding in the brain is 21 to 28 days in any individual. Single user can be detected in 3 days, and longest duration can be detected in 21 days. Different methods is used in overall the world in to detect the substance use into any individual. Coming to the heroin use, if individual started heroin, they feel euphoria, irritability, altered perceptions, depression, lack of motivation. If they comes with the intoxicated state, they have concentration problem, pinpoint people, respiratory rate decrease, dryness of mouth, and respiratory depression. When they come with the present with the withdrawal symptom, they develop nausea, vomiting, abdominal pain, cramps, rhinorrhea, um, chills. That depending on the mode of use and the quantity is used by the individual, that vary to 7 to many weeks. It can be detected up to 28 days, but it depends on the use of the opioid derivative use. Methamphetamine is the challenging drug in Pakistan. It has a euphoric effect, irritability, anxiety, paranoia, grandiosities. When they comes with the intoxication, they have cardiac changes, tachycardia, tachypnea, chest pain, cardiac arrest. When they started the withdrawal after the 12 hours, and they prolong with 72 hours, and we can detect it to 9 to 96 hours. It can be detected by the urine in Pakistan, but internationally they can be detected by the saliva and hair follicles methods. Benzos are the most commonest drug used by the women drug group in Pakistan. It gives them irritability. If you the user irritability, agitation, relaxation, concentration, confusion, sleep disturbance started with them, then they comes with intoxicated. It's a majority of the overdose used by done by the females are benzos, benzos drug use. They comes with the withdrawal effects. They have restlessness, agitation, confusion, psychosis, perceptual disturbance. The benzos effect depend on the half life of the benzos which they are used by the individual. It's usually detected into weeks to hours. Alcohol is the mainly used in the upper class of the Pakistan, and it has the different effects on the individual. They give an euphoric effect, change in moods, inhibitions, coordination, lack and memory issues. When they intoxicated state, they have a sluggish speech, ataxia, gait problem, confusion, drowsiness, agitated behaviors, and hallucinations. When they come with the withdrawal effects, they have a nausea, vomiting, perceptual disorders, hallucinations, delirium tremors, and other symptoms they presented. The duration of the withdrawal is around 5 to 7 days, may be long if the use are chronic. It can be detected in the alcohol in Pakistan only. These are the common drugs used in the Pakistan: cannabis, crystal, opium, heroin derivatives are commonly used by the drug users in Pakistan. Coming to the etiological entity of the substance use, the three major factor is contributing factor to the substance use. Individual factor, it's genetics, and environmental factor leads to started with the individual with substance use. Gradually they develop a compulsive behavior by the neurotransmittal changes, and then they have dependent with the drug, and after dependency of the drug, they haven't. When they stop any drug, they have a withdrawal effects, which leads to be a negative reinforcement to individual, and he started regain the drug. And which these are the main key areas which are involved in the brain of the prefrontal cortex, equus, and ventral tegmental area, the key areas which were involved in the substance use mechanism. To just given an overview of what effects drug gives into how long, how increase in the dopamine in combination of the drug after the using of these drugs. These are the different drugs. Natural we can give only 50 to 100%, and methamphetamine is the highest 1000% increase in dopamine. These are the PET scan of a cocaine user, which shows the orbital from frontal cortex metabolism decrease in the substance user. These are the screening tool. When an individual approach for the drug treatment, we go for the psychological and screening and biological screening. Psychological screening depends on the different rating scales what you use to identify these. The assist, audit C, catch, darts, NIDA drug used screening to Figertroms for the nicotine. These scales are used to identify the drugs. For the detailed assessment of the individual of substance use, we comprehensive detailed history of individual and addiction severity index are solely used by and recommended by the WHO to assess any individual. Addiction severity index has a different component which covers all areas of the individual, including medical, psychological, and social issues of the individual. Severity of the alcohol dependent question is also applied. Severity of dependence also scale are also used to assess the severity of the dependence, and overall the system assessment criteria as opioid treatment index are used to assess the service quality of the system. These are the overall management, pre-treatment, primary treatment, case management, and components. Pre-treatment, outreach services, brief interventions, assessment, and primary is the key subject: pharmacotherapy, psychotherapies, therapies, 12-step facilitation, case comorbid management, life skill trainings, and the case management is the referral and linkage development and monitoring and ongoing services to continuous of care is depending on the relapse prevention, monitoring and evaluation, coordination, other services, and facilitation to the individual. These are the warning signs of the physical warning signs and the emotional warning signs and family warning signs and social warning signs of the individuals. Depending on the individual, we need to assess individual or which symptoms are appearing. These are the main key signs which are present in mostly the youth of the which was showing that they needs help to the mental health professional. Coming to the same prevalence, these are the statistical data of MATRC Karachi, in which heroin is the most common drug used by the drug users. Then is crystal and ice. Then is cannabis user and prescribed drugs. Then other drugs. The age group. This is an alarming situation in Pakistan. The age youth majority, 80% of the youth is using drug. The highest drug group is 20 to 30. The reason of the drug user is the major reason of the drug user is the peer pressure and friend group, and then fun and pleasure, then frustration and curiosity, sex and pain is the alternative options of the adopted by the indoor patients reported in the Meteorology Karachi. These are the reference which will help to present the presentation. Thanks for the patient listening.
Thank you, Dr. Mohammed Tarique, for the wonderful presentation. Now we have a live speaker, Dr. Nasir Shah, and he'll be discussing about sleep well and be well. Dr. Nasir Shah is currently working as a Dean of Family Medicine Faculty at the College of Physicians and Surgeons, Pakistan. He's a convener of National Medical Family Medicine Council. He's an examiner for MCPS, FCPS, and MRCGP International. He has also headed family medicine at Fatma Memorial Hospital, Lahore, and University of Health Sciences, Lahore. He has pioneered distance learning CMEs for family physicians in Pakistan and has been involved in uplifting of family medicine in Pakistan since past 19 years. He is famous for his innovative ideas and jolly lectures. Dr. Nasir, you have 20 minutes for your presentation. Over to you.
Let me share my screen first. Can you all see my screen?
Yes, Dr. Nasir.
Okay. Bismillahirrahmanirrahim. Assalamu alaikum everyone, and thank you the team of Icon for inviting me to this presentation. And topic you have given to me is a dangerous one. If it's too good, people will know how to go to sleep and they will sleep. I'll be in trouble. If it's too boring, they will definitely go to sleep. So I'll try to keep it somewhere in the middle. So the topic is sleep well, be well. And before I start my scientific component, let me share some of the sleeping habits of the genius people. Like Einstein, he used to sleep 10 hours a day. He was very fond of sleeping. And plus, in the daytime, he would take naps. And he once said, "Don't give up your dreams, keep sleeping." He was famous for his sleeps. On the other hand, there are other genius people like Newton. He only slept 3 or 4 hours at night. Sometimes he would work for days and days until he become exhausted and will fall down. People will carry him. Nikola Tesla, one of the famous engineers and entrepreneurs, and he used to sleep 2 hours only. Graham Bell, who invented telephone, and he slept for 4 hours, maybe 5 or 6, not more than 6. And his sleeping cycle was inverted. He used to sleep in the day and work at night. The famous lady, the lady with the lantern, Florence Nightingale, the mother of modern nursing curriculum, and she used to sleep 4 hours. Even in the wars, she would wake up every hour and look after the patients. The man who had the longest list of inventions, Thomas Alva Edison, his sleeping cycle was separate from all of them. He would not sleep. He would wake up for 3 hours and then take a nap for 20 minutes, 25 minutes, and then wake up and start working. So, looking at these weird sleep cycles, it seems like they were determined to work hard to do good for the families, but not for their health. So, because now we know that sleep is good for health, now we have found all the scientific basis to find out that a good sleep will enable the repair and maintenance work in your body. The wear and tear that occur during day is repeated at night. The immune system is boosted at night. If you have good sleep, all the chronic conditions, diabetes, hypertension, degenerative, everything that slow down. If you're sleepless, everything increases. So good sleep gives you a good memory, good mood, and prevents depression. And the if you have good sleep, physically you are fit and you feel strong, you feel energetic, you want to do things. And last, as also mentioned in the previous presentations, the hormones, especially the steroid hormones and all the body physiological things, they are linked to the day and night cycle, including weight. So the time you eat, the time you go to sleep also determines your hormone level and the weight management. And this has been published in the American Heart Association. This importance of sleep is so much that in 2014, exactly with this slogan, sleep well and be well, this was the slogan of a national campaign by three organizations: American Academy of Sleep Medicine, CTC, Sleep Research Society. So to promote, to spread the awareness about good sleep. So now we know that good sleep is good for health. So, but how to get that beneficial sleep? Looking at the weird sleep cycles of the genius people and people around us, and based on our experience, so how to get that beneficial sleep? Because modern day life is too busy. The schedules, the timings, the social media, the screens, the schools, the work, and so much which will not allow us to have a good sleep. So the main purpose of my presentation would be to highlight those aspects of sleep which will help us, help our families, help our patients to have a good sleep within the current era. So it all starts with the circadian rhythms. We all know that there is an internal clock in every living being, including humans. So the body systems, the physiology is linked to that internal clock and is not in control. So the blood pressure, the pulse, the respiration, body temperature, the sleep, the hormones, they all have a cycle, inner timetable. And that's the basis of understanding the sleep. So this is a simplified version of the circadian rhythms. Okay. So half of the circle shows the daytime and half shows the nighttime. And I will bring your attention to some of the important parts. 9 p.m. the 9 baje ka khabarnama. 9 p.m. Because at that time the melatonin secretion starts. Melatonin is the substance that starts that wear and tear and the beneficial effects of sleep. The second important is 2 p.m. At 2 p.m. you get the deepest sleep. It's not the early morning, it's 2 p.m. So in between 9 p.m., if you go to sleep 1, 2, 3, 4, and 5 hours, maybe 6 hours, will give you the best sleep in which you will get melatonin, also enjoy the deep sleep. And if you look at the circadian rhythms, the early part of night, and there's a peak of body temperature, neutrophils, lipid profiles. There's many activities in the early part of night, and on the other hand, there are other activities surges in the early part of morning, which implies that the early night and the early mornings are the important parts. Rest of the day and rest of the night do not have those peaks. So National Sleep Foundation also did research on people, and they found factors which enhance good sleep. So these were subjective things they asked people. So a few things we all know can promote sleep. This is called sleep hygiene. Like quiet room, logically, a dark room. There should not be so much lighting in the room. Cool temperature, not very cool that you are shivering, but slightly cooler than your body, so you feel sleepy. Fresh air, there's no dust, no smell, and the clean bedroom, the hygiene is good. But if you look to these people we see in our country, the children lying in the area which is neither clean nor quiet, not dark, neither not dark. But how do they sleep so peacefully and deep? So there must be other factors to have a good sleep. White noise. So if their sleeping place is not quiet, but white noise, the continuous monotonous sounds, they also help in going to sleep. One of the example is Lori, the sleeping song by Mother. Allahu Allahu. The monotonous sound, they put you to sleep. And many times the lectures, they put you to sleep because of the white noise of the speakers. And then many of you are young, but when we were children, there was a PTV which end at 10 o'clock with the national anthem. You go to the room, you'll find many people sleeping, and the humming sound of the television. So that was the other thing. These children, the street children, they walk and run all the day, so they have good exercise. So exercise also promotes it. So any exercise which is aerobic be it cycling, swimming, any one of them, or dancing, anyone. But the simple, easy thing in the Pakistani situation is a walk. And the walk should be in the daytime, not at night. Daytime aerobic exercises will promote good sleep at night. The other thing, eating less. Heavy meals at late at night, they will not promote good sleep. So if you take dinner late, keep it half. So these children also do not find food to fill their stomachs. They eat less. So full stomach, late dinners, they do not promote good sleep. For good sleep, you must take light dinner early, at least 2 to 3 hours before the bedtime. Milk, now it's proven that the latest research done on patients, they were given, some were given milk and some were not given milk. The patient who took milk, they've had better sleep because milk has tryptophan, an amino acid, and it starts the process of melatonin and serotonin, so it does improve sleep. Hygiene before sleep. So to the two cultures that we quoted, Chinese and Japanese, they take bath before going to bed, and we know that hot shower can enhance sleep. And the Messenger of Allah, sallallahu alaihi wasallam, also had that habit of most of the times, wuzu at night, and also sometimes when needed ghusl. So hygiene before the sleep time also promotes good health. Regarding your bed and especially the mattress and the pillow, you will find so many types of mattress: spring mattress, soft and hard, and charpai, and the bed so much. Usually does not matter. People are used to their mattresses. For pillows, the main concern is the neck and the spine. So for supine sleeping, a small pillow, and for sleeping on one side, you need a pillow that supports the spine. The principles of mattress and the pillows are comfortable and supportive. But if you come to these children, if you look at the pillow of this child, so this pillow and the mattress factor they do not seem to be very important. Their other factors seem more important. In sleeping on the ground, there are cultures where people sleep on the ground, like Japanese, Chinese, and Central Asians, Iranis, Afghanis, the old Arabians, now they sleep on the bed. So it promotes better sleep. Now we know, now modern science is finding that grounding or earthing, when you sleep on the ground or sleep, this especially go to lie on the ground on the earth. So they think the natural electric charge of the earth uh, stabilizes the inner physiological process of the body, reduces inflammation and pain, reduces stress, it promotes sleep, and gives you better energy and well-being. Then last, you will find students and people who sleep in the day and work at night. So which time of the day is better, day or night? So Allah subhanahu wa ta'ala said in the Quran, He is the one who has made the night for you as a cover and sleep for resting and the day for rising. So definitely daytime sleep is not beneficial. It's the night time, and we know from the circadian rhythms. And the Holy Prophet sallallahu alaihi wasallam said, one should not sleep before the night prayers, the Isha prayer, nor have discussions after it. Meaning that you just after the Isha prayer go to sleep. And if you look at the circadian rhythms, 9 p.m. melatonin starts. And usually the Isha time is 1.5 to 2 hours after the sunset. If you compare the Maghrib and the Isha, so you take dinner at Maghrib and sleep at Isha, so you will have your stomach will be half empty, and you will get the benefit of serotonin. Let's discuss the stages of sleep. Just a very simple version. Just like the gears of a car from 1, 2, 3, and 4, and 5, sleep also has gears or stages. So when we go to the bed, we start with stage one, which is very superficial and light. And stage 2 is deeper, 3 is more deeper, and the deepest is stage 4. And the sleep starts with these 4 stages. And then there are a period of rapid eye movement, as you must be seeing in the picture. When the patient is sleeping, the eyes are moving. So this is called sleep cycle. Let's spend some time on the stages of sleep. So if you can see my cursors, when you go to sleep, you start with the stage 1, which is light. Then you go to stage 2, which is deeper. Stage 3, even deeper. Stage 4, even deeper. So this is the deepest part, the relaxing part. And you stay there in some for half an hour, and then you reverse direction. You go to 3 and then 2. You don't go to stage 1 again. And then there is a rapid eye movement sleep. So this is called a sleep cycle. So these cycles are repeated during the night. So it is interesting to note that the initial 2 cycles will be in, you go to stage 4, which is the deepest. So in the initial 2 cycles you get the best deepest sleep. And if we include the stage 3 here, so then 4 or 5 hours you get your deep sleeps. But after that you just enter the stage 2, which is relatively superficial sleep. So the rest of the night are the superficial sleeps. Hazrat Aisha Raziyallahu Ta'ala Anha told Sahaba that the Messenger of Allah Sallallahu Alaihi Wasallam used to sleep in the first part of night and stay awake during the later part. So this explains the scientific basis that the later part they do not have that deep sleep. So the people who wake up at night for tahajjud, they usually do not lose the benefits of having shorter sleep. And there was another study. They found out what happens if you sleep more than 9 hours and less than 9 hours. So there were 2 groups of 30,000 people sleeping less than 9 hours and 9 hours or more. They found that the risk of stroke increases if you sleep more than 9 hours. If you sleep for more than 9 hours and also sleep more than 90 minutes in the daytime, even the risk of stroke increases to 85%, which is a lot. The other part is some people sleep in the morning. So the Prophet sallallahu alaihi wasallam said he used to offer morning prayers and sit there in the mosque with the crossed legs till the sun arose. So he would not go to sleep after the Fajr prayers. And he prayed for us, the people. Oh Allah, bless my people in the morning times. And Sahaba, the companions, utilize that prayer, and they will they start their wars and merchandise and work and business very early in the morning. So the blessings of Allah are in the early mornings. So this sleep and wake timings were very nicely set by Benjamin Franklin. Early to bed and early to rise makes a man healthy, wealthy, and wise. So wealthy is also appropriate and true. Wisdom is also true. So sometimes your body needs rest, sleep, and you do not sleep that much. So there's a deficiency in your sleep. This is called sleep debt, udhar, loan. So the people had tendency previously that they would go to sleep on the weekends for long hours. They overslept in the morning. So, but now we know that's not the good solution. Oversleeping on the weekends is not the appropriate repayment of the sleep debt. The best is to regularize your sleep cycles. Go to bed in the same time and wake up at the same time. That's the best method of paying or repaying the sleep debt. Because if you're sleepless or sleep deprived, you get small micro sleeps. As the name shows, micro means very small, small sleeps. So these are few second periods of sleep, and they're quite common. And the eyes are open, you're awake, but actually you are sleeping for a few seconds. And that's the most dangerous reason for having accidents on roads. I personally have noticed that once we were traveling I was exhausted and traveling from Lahore to Islamabad and to Peshawar in the morning. The road will vanish from my vision for a few seconds. I start my car and ask the other person who was a guest from WHO, Dr. Gahar Wajid. I asked him, Dr. Gahar, please you drive. I can't drive. I can't see the road. So and once I remember, I had a micro sleep and my car on the motorway with my family. I hit the middle concrete part. So, but usually I take that stop my car and take nap. So micro sleep is a very dangerous thing. So while driving, how can you recognize that micro sleep is coming? So thoughts instead of the road and you start thinking of other things, and then you drift in the lanes. Then you have passed a certain point, and you forget whether the station has passed or not. So at that time you must be in sleep, and you feel drowsy. So in the motorways, they have lay-by areas where you can take rest. So when you find many people sleeping in the day, the Japanese are famous for this, and all of them are sleeping in the metro buses. Is it good or bad? It's good. So naps are not bad in the daytime. The nap should be a nap of 20 minutes. So many genius people, they usually took small naps or 20 minutes, brief, not sleeping for 3 and 4 hours. Nap is a nap, is a brief period. I take my naps on the chair. Is the best part for me. So a nap will refresh your body and the mind, and will enable you to give you better performance for the next few hours. It's a temporary relief to the mind and body. Please mind it. It's not the substitute for a good night's sleep. It is a temporary measure. So, Holy Prophet Sallallahu Alaihi Wasallam also told Sahaba that if any one of you feels sleepy and drowsy while praying, you should go to sleep till you understand what he's saying. So it means that there is no time for a power nap. If your body and mind needs a sleep or refreshing things, go to sleep, a brief sleep, and refresh yourself. So this is my last slide. I might have finished early or late, I don't know. This may be the briefest summary you have ever seen in your life for sleep, good sleep, which makes you well. Follow your nature. Uh, Go to the bed early, wake up early. Okay? And you follow the nature of circadian rhythms. Your body will follow, your mind, your body, your soul, the physiology of digestion, sleep, memory, cardiovascular, respiratory, inflammation, everything will be in rhythm with the nature. Thank you so much.
Such an
So,
exciting
if you have
presentation.
time, how much time do I have?
Dr. Nasir, we are on time.
Okay, okay. So I'll stop sharing, not go to the treatment of insomnia. We
Right.
may take questions.
Uh, Dr. Nasir, thank you for such an exciting presentation. We'll be taking question answers shortly after the last presenter.
Okay.
Thank you. Okay, now we'll be moving to the last presentation of today's session by Dr. Sobia Aftab. Dr. Sobia Aftab is an associate professor of clinical psychology at the Institute of Clinical Psychology, University of Karachi. Dr. Sobia has been awarded a postdoctorate in clinical psychology under Fulbright Postdoc Visiting Scholar Award by USA. She is practicing as a clinical psychologist, board certified instructor for hypnotherapy, USA Internationally Certified Addiction Professional. Besides, she is an assistant editor of PJP and an assistant book reviewer of PJCP. She's a member, editorial, and advisory board of various national and international journals. She also has various publications to her credit in nationals and international journals. Today, Dr. Sobia will be discussing about social relationship and mental well-being. Please, Dr. Sobia.
Assalamu alaikum, everyone. This is Dr. Sobia Aftab, Associate Professor of Clinical Psychology at Institute of Clinical Psychology, University of Karachi. So today I'm going to talk on the connection between social relationships and mental well-being. So in order to understand the significance of social relationships for mental well-being, first we need to understand what does it mean to be mental well-being. Mental well-being is a term which is alternatively used for mental health. The World Health Organization defines mental health a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life and work productively and fruitfully, and is able to make a contribution to his or her community. This definition implies mental health is more than the absence of mental disorders. In order to understand the importance of mental health, let's look into the World Health Organization's definition of health. WHO defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. This implies mental health is an integral and essential component of health. There is no health without mental health, and mental health is essential to our overall well-being. And mental health is as important as physical health. Social relationships. So what are the social relationships? There are three kinds of social relationships all of us have in our lives. Intimate connections that we have with the people who love and care for you, such as your friends and families. Relational connections that we have with people who you see regularly and share an interest with, such as your workmates, co-workers, and the collective connections that we have with people who share a group membership or an affiliation with you, such as people who have the same faith. This can be like the people who share same religious faith. So why are social relationships important? Human beings are social animals and therefore naturally seek the companionship of others as part of their well-being. Being connected to others socially is widely considered a fundamental human need, the need to belong, like we have other needs, eating, drinking, or sleeping. And our bodies react to the loss of that interaction the same way they react to the hunger. It's physically painful, it's damaging, it's even dangerous in long term. Some examples include infants in custodial care who lack human contact, fail to thrive, and often die. Prisoners often punish offenders by putting them in solitary confinement, depriving them of the company of others. Perhaps the most obvious expression of the need to belong in contemporary life is the prevalence of social media. The significance of social relationships in context of mental well-being has been documented by a large number of studies. Social connectedness is regarded as the social cure that acts as a psychological resource that protects one's mental health, particularly in times of adversity. This is so important that World Health Organization and National Health Service regard social relationships crucial to mental health and well-being. Even the social connectedness is regarded among 5 steps to improve mental well-being by National Health Services. So what does the social relationship do to our mental well-being? Strong relationships can help you to build a sense of belongingness and self-worth. They give you an opportunity to share positive experiences. They help you to strengthen your immune system. They help you to recover from disease and may even lengthen your life. Strong and healthy relationships can build up during times of stress and often gives them the strength to carry on and even thrive. So they help you in building your resilience. They help buffer the effects of risk factors in people's life, and they serve as a protective guard against a range of psychological problems, including substance use, depression, anxiety, suicide, and range of other mental disorders. Social and healthy relationships can provide you emotional support, that is, a sense that one is loved, cared, and listened. Eventually, this helps to reduce the damaging effect of stress and can foster a sense of meaning and purpose in life. So in short, we can say the social relationships act as a source of support and being an important coping resource for dealing with pain, stress, and difficult life events. They provide us with a sense of connection, purpose, support, and ultimately overall mental health and longevity. So how the social relationships can be built or improved? There are certain ways we can build on we can improve our existing relationships in 3 domains I have spoken before. Take time each day to be with your family. For example, at least eat dinner together. You can arrange a day out with friends you have not seen for a while. You can switch off the TV to talk or play a game with your children, friends, or family. You can have a lunch with a colleague or a co-worker. You can visit a friend, a family member who needs support or company, as research evidences suggest that the act of caring for another person can release stress-reducing hormones for both the giver and the receiver. You can join networking, social or special interest community groups that meet on a regular basis. You can consider volunteering, which lets you help others, as it has been seen that the volunteering can boost your self-esteem and is a great way to meet new people. It has also been seen to elevate mood and reduce symptoms of depression and anxiety. In addition, you can also make the most of technology to stay in touch with friends and family. There are a lot of video chat apps like Skype and WhatsApp. So if you're living far apart, you can utilize these technologies to connect to people. You can use Facebook and other social media because they're also great ways to stay in touch. But I would say, do not rely on technology or social media alone to build relationships. If you have the opportunity to connect with people physically, because it's easy to get into the habit of not only texting, messaging, or emailing people. So just be cautious, not only rely on technology and social media. Because it has been seen that face-to-face contact release a whole cascade of neurotransmitters. And they work like a vaccine. They protect you now in the present and will in the future as well. Such as shaking hands. Giving somebody a high five is enough to release oxytocin, which increases your level of trust and it lowers your cortisol level. So it lowers your stress. Dopamine is also generated, which through shaking hands or giving a high five, which gives a little high and it kills pain. It's like a naturally produced morphine. So granted, COVID-19 has put a damper on social opportunities, but there are still opportunities to safely interact with new people. You just have to look for them. If you don't feel comfortable being around in large group, then take part in activities involving smaller groups, because social relationships are key to mental well-being. So I would like to end my talk on these lines. Alone, I can see, but together we can talk. Alone, I can enjoy, but together we can celebrate. Alone, I can smile, but together we can laugh. That's the beauty of human relationships. We are nothing without each other. So stay connected and stay mentally healthy. Thank you so much.
Thank you, Dr. Sobia, for such an informative presentation. Now we'll be taking question and answers regarding today's session. I request all the participants to please write your questions in the chat box. You all will have access to the presentation of all the speakers in today's session. It will be available on the portal of ICON 2022. You can access the presentation at your convenience. Please don't forget to fill in the feedback forms. The link is being shared below in order to get a CME certificate for attending the session. Any question answers? Okay. Dr. Tarique is asking what is the role of. Okay. Okay. For Dr. Tarique, there's a question. What is the role of family physicians uh, in convincing people with substance abuse?
Hello, Ji madam, can you
Yeah.
repeat the question?
Yeah, sure. Dr. Tariq, the participants wants to know what is the role of family physician in counseling patients with substance abuse.
Uh, in current scenario of Pakistan, the primary physicians have a key role to identify earlier identification of the substance use in Pakistan, referral to the treatment centers established in Pakistan, or tertiary cares for the indoor facilities of the substance users.
What about the chronic use of benzodiazepines by patients and prescribed by the doctor sometime, and they're taking for prolonged periods of time, 2 to 3 years, high doses? So how do we cut it down? Because all the patients, if you refer them,
Uh,
also they don't go to the referral centers.
Unfortunately, in Pakistan, we majority of the benzos are prescribed by the GPs and the primary physicians, not by the psychiatrists and mental health professionals. So, keeping in the view on the dosage and the quantity of the benzos, we gradually taper off the dose of the benzos and manage accordingly, keeping in the side effects of profile of the psychoactive component of the benzos group. Majority of the users are low quantity users. They are not taking too much quantity in reporting to the primary physicians. They can manage easily with gradually tapering dose of the benzos with selective underlying treatment of the depression and other mental disorders, and they can refer to the tertiary centers of the JPMC, civil hospital, and other any teaching hospital for the further management of the case. Any other?
Thank you, Dr. Tariq. We'll let you know. Professor Nasir Shah has a comment that benzodiazepines are written by family physicians, specialists, psychiatrists, medical stores are also, and people are also using it on regular basis by self-medication. So we need to look into it to decrease their use. Okay. Dr. Hina wants to know what is the best time to take power nap in daytime and how many times anybody should take power naps. Dr. Nasir.
It's a good question. I mentioned in the slide as well. There's no actually the fixed time for a power nap. It's the demand of your body and mind. So in principle, you can take nap anytime you feel drowsy. But if you might want to make a pattern or a schedule for a sleep nap, is the best time is in the midday, mid of the day, where there's no peaks of any hormone or system. So, and that gives you a good sleep for the rest of the remaining day. See, so in short, on need basis anytime, but for a schedule, middle noon is the best time.
Okay.
And that was
Any
followed by the Holy Prophet as well.
Yeah.
Sallallahu Alaihi Wasallam, he used to have a nap after Zohar prayer.
Okay. Okay. Any particular time, Dr. Nasir? The sleep, the power nap should be like 10 minutes, 20, 30.
Duration is
Yeah.
usually 20 minutes, 20 minutes plus maybe 5 6 minutes, 20 minutes,
Okay.
or maybe
Okay.
half an hour, not more than that. Some people take it for 10 minutes, 15 minutes. Like Zulfikar Ali Bhutto used to take a power nap of 10 minutes.
Okay. Okay. Dr. Gulshan would like to know if there are any medicines we can give to our patients for sleep and those which are safe,
Yeah.
not causing any kind of dependency.
Yeah, for that you must divide people into two groups. Like what is primary insomnia, like people without reason they don't feel sleepy, and the other is a secondary insomnia. Like for example, in depression, people may not go to sleep. Insomnia is part of depression. Hyperthyroidism, any chronic pain, polymyalgia rheumatica. So many. There are secondary reasons. You try to sort out the reason for the insomnia. That's the best thing to do. If it's depression, treat depression. But if want to help the patients to go to sleep quickly for to have a sound sleep, um, there are drugs available. For people with primary insomnia without other reasons, melatonin is used. For sleep induction, these Z groups, zolpidem and the other two drugs starting with Z, they can be used. The short-acting benzodiazepine, like temazepam, they are also indicated, but not for prolonged periods. And they're over-the-counter drugs which are used by the patients. And like they used first-generation antihistamines like phenyramine, chlorphenyramine, hydroxyzine. So they use it over-the-counter. Uh, Tricyclic antidepressants, sometimes in chronic pains, people with stress, tricyclic antidepressants are used widely, even in UK. But randomized control trials on the role of TCAs in primary insomnia is still not confirmed, but they are very good drugs. But we should be cautious about elderly and male elderly, especially because of prostate issues. So these are the
Okay.
groups that are available. One of the example in children is Phenergan, the uh, promethazine syrup. It is used widely by the mothers.
Right. Dr. Hiba wants to know, can melatonin be prescribed in patients with diabetes as sleep inducing agent?
Um, I don't know exactly, but for primary insomnia, it is recommended age 55 and above. They can use it for 3 months
Okay.
for reduced sleep. But if and the main reason, like in psychiatry and mental health, when these symptoms or conditions start affecting your life, your relationships, your health, personal life, family life, social life, professional life, then you must treat them. So then I think short acting benzodiazepines can also be used.
Okay. Dr. Vinod wants to know, is there any genetic component related to sleep?
Yes, of course. There are in families, sometimes everybody gets a very little sleep. Sometimes the whole family is so sleepy. So two families. So it is there. But there are other factors like stress, the sleep hygiene, medical conditions, drugs. So many things have a role to play. And plus your own habits. For example, your exercise, your late dinners. So these things also have a role to play. It's a multifactorial thing.
Okay. Dr. Safdar is telling us that Napoleon used to take naps on horseback. So that's interesting.
Yeah.
Dr. Shabnam
I,
wants to know know the role of melatonin for sleep disorders.
yeah. Melatonin is the I said. that the substance that released naturally in the body is melatonin, that induces sleep and repairs the body. That's a very logical substance to use in sleep. So it resembles the natural sleep cycles. So that's why it is being researched and used. And in future, it will have more place in sleep health.
Okay. Any other questions? Okay. I thank you all for attending the session on lifestyle medicine. Thank you for making this session interactive. Enjoy further sessions with ICON 2022. And I would again remind you all to please fill in the feedback forms. They're attached to the link below showing on your screens in order to get the CME certificate for attending the session. Goodbye. Thank you.